Hi everyone, thanks for listening to my presentations. Today I'll be talking about dysphagia aortica. Someone is asking, what? Dysphagia aortica? Trying to tell me that swallowing difficulty could be caused by aorta? Oh yes, that's just it. Okay, sit back. Let's find out how the thoracic aorta could be responsible for that swallowing difficulty. Okay, dysphagia aortica is a rare condition. Glad to know that. We don't want all these anomalies around, right? It is very common in elderly. It is a mechanical cause of swallowing difficulty, otherwise known as dysphagia. It is extrinsic. Extrinsic in the sense that it is not a problem within the esophagus itself. It is happening outside the esophagus, now compressing the esophagus. Dyshagia aortica will occur as an anomaly of the thoracic aorta. So we're getting to the bottom right. Thoracic aorta is having problem, and that problem is having effects on the adjacent structure, the esophagus. So is either the thoracic aorta is tortuous, or is having massive aneurysm, or is even having dissecting aneurysm, or it is ectatic, which means the thoracic aorta is greater than 2 centimeters in diameter, or there is atherosclerotic situation going on here. Risk factors here will essentially be that the affected individuals will be elderly and more in women. I don't know why that, but that is what we got from literature review. Okay, more in women, particularly women with short stature, is associated with hypertension and the history of thoracic aortic aneurysm, and of course, gastroesophageal reflux disease. What are the clinical features? There will be dysphagia to soils, shortness of breath, nausea, edema, kyphosis, short stature, regurgitation, and hemoptysis. Other clinical features will include dizziness, heart racing, chest pain, heartburn, wheezing, and ejection murmur. How do we make the diagnosis here? We have to take a thorough history and thorough physical examination. We can do chest x-ray and CT scan. Barium swallow study will be welcomed, and we have endoscopy with aortography that will help better. And of course, manometry will tell us what's going on within the esophagus itself. We can add to lab because of the associated risk factors, right? So we can have renal function test done, the glucose level, the lipid, basic metabolic panel, hemoglobin and complete blood count, liver function, and thyroid function test done. Treatment could be treated medically with diet modification. In that case, we will advise affected individual to change lifestyle. Eat small amount of food. You can eat more than you should. Eat frequently, but small. Then chew the food very well before swallowing. Okay, don't lay down immediately after eating. That's the way we've been advising people with gastroesophageal reflux disease, right? Treat any associated condition or conditions found, like heart failure, gastroesophageal reflux disease, and referral to orthopedics to handle the kyphosis. Okay, still on treatment. We can make use of proton pump inhibitor like omeprazole, particularly when we're dealing with gastroesophageal reflux disease or you just deem it fit. Okay. Then we can use metoclopramide because it is a prokinetic agent, not because of nausea and vomiting only, but this time around we need the content of the gastrointestinal tract to get them pretty quickly. Okay, so we can use that, but we need to watch out for the horrible side effects of extrapyramidal-like side effects. You can check my channel for that. I have a full presentation on metoclopramide already published. We can use calcium channel blockers or tricyclic antidepressant when we think we should be able to relax the smooth muscles and then decrease the pain. And of course, we are dealing with aorta here, where we are thinking, oh, this might be associated with hypertension, with heart failure, and aneurysm. So using AC inhibitors or beta blockers is not out of place. And of course, diuretics will directly affect heart failure by decreasing the fluid, okay, and so on. Now, surgery. Surgery could be definitive and curative. And why that? If this is a case of massive aneurysm and cardiothoracic surgeon is involved and the aneurysm is repaired, what else? The story is over. No more problem, right? And of course, we could also involve the services of the surgeons to have gastrostomy done. And they can have percutaneous endoscopic gastrostomy, PEG, and then life will continue from there. And you can use bougie to dilate the esophagus, but here's the one. We need to find out whether or not there is massive aneurysm of the thoracic aorta before employing, bougie to dilate. Because we might teach massive aneurysm to dissecting aneurysm when we are using the bougie to dilate. And we don't want that, because if that is the case, we will need urgent medical surgical intervention to save that life. And nobody is going to be ready to teach anybody to that level. And with that, I've come to the end of this short presentation. Please remember to share, remember to subscribe. You are free to leave comments on my channel. I appreciate it. Thank you.